Welcome back to This Emergency Life. I'm Kevin LaMonica, and today we are chasing a killer that lurks behind common symptoms, pulmonary embolism. Every year in the US, between 600 and 900,000 people develop venous thromboembolism, and roughly a third of those present as pulmonary embolism. Nearly 100,000 lives are lost, accounting for about 10% of in-hospital deaths. PEs, they're stealthy, deadly, and demand our utmost vigilance. Our story today begins with you being about halfway through your day shift and you receive a pre-notification call on your red phone from Medic Unit 46 William. 58-year-old male just off a nonstop flight from Seoul, South Korea. The time in the air was about 14 hours and 15 minutes. Patient has a history of multiple myeloma and recent chemotherapy. His heart rate is 132. His respiratory rate is 28. And he's only saturating 88% on the non-rebreather they've had him on. ETA 2 minutes. Upon their arrival, and before the patient can even round the corner into your notification area, you are executing the primary survey. You go ahead and you confirm that the airway is patent. Your respiratory therapist is already prepping a high-flow nasal cannula. You listen as the lungs sound amazingly and deceptively clear. You check circulation. Their blood pressure is 98/60. You note jugular venous distension at about 45 degrees as they lay in the stretcher. You go ahead and you secure 2 large bore IVs, drawing labs for CBC, CMP, D-dimer, a troponin. You also want to check a BNP and a blood gas. The ECG leads go on next. They reveal sinus tachycardia with a subtle S1Q3T3 whisper of right heart strain. A 250 ml fluid bolus begins while we are preemptively prepping a norepinephrine drip. The EKG is a valuable tool in assessing patients with possible pulmonary embolism. The waves have distinct patterns that you can learn to recognize in the right clinical context. Common EKG findings are sinus tachycardia, right bundle branch block, a new rightward axis, the S1Q3T3 phenomenon, and any new T-wave inversions inferior or anteriorly or both. These are all signs of acute right-sided heart strain. And that's exactly the pathophysiology one would expect to see in a patient experiencing a sizable blood clot in the pulmonary vasculature, causing increasing pressures backing up into the right side of the heart. The rapid interventions that you deploy buy time and they unmask data. And they're exactly what we'd hope every emergency nurse performs when the diagnosis of massive PE is on their radar. Rudolf Virchow was a physician who specialized as a pathologist. He first described the triad of stasis, hypercoagulability, and endothelial injury way back in 1856. He theorized that clot formation arises when blood flow slows, when the blood clotting factors are influenced, or when vessel walls become damaged. Today, our patient checks all 3 boxes. He has venous stasis from the marathon flight he just got off, hypercoagulability from his multiple myeloma diagnosis, and the high potential for endothelial injury from the chemotherapy he's received and possibly invasive IV lines that he's underwent for that therapy. Virchow's triad isn't a museum piece. It's our mental model every time we suspect a clot. Yet, history and physiology only take us so far. We need to maintain a high index of suspicion because no scoring system or isolated vital sign will catch every case. Tachycardia shows up in only approximately 25 to 30% of PEs. Hypoxia may have 1,000 causes. ECG changes range from non-specific T-wave inversions to essentially a completely normal tracing. That's why clinical gestalt trumps any one of these tools. Speaking of tools, we'll use the Wells criteria to quantify our risk and the PERC rule to safely exclude very low risk patients. But we never let a numerical score override the story our patient tells us. If the Wells criteria gives us low to moderate probability and the PERC rule is negative, we may hold off on any workup at all. We might be done. But if a D dimer spikes, or if the presentation screams clot, despite a low score, we're going to push forward. Alternatively, if a patient is risk stratified as high risk for PE with a normal D dimer, it should not deter from obtaining a more definitive study like a CT pulmonary angiogram to rule out the disease. D-dimers have value in ruling out low-risk patients, not the ones you are fairly sure have the diagnosis. In our case today, the D-dimer just happens to return markedly elevated. We don't linger. CT pulmonary angiography is the gold standard, with a sensitivity in the low 90s and a specificity approaching 98%. As the CT scanner hums, our bedside echo probe confirms a dilated right ventricle and septal bowing. This is known as sign, lighting up your ultrasound screen. Then the CT slices reveal a classic saddle embolus perched across the bifurcation of the main pulmonary arteries. This is massive PE, and our patient is hypotensive. So it is time to move. Systemic thrombolysis with alteplase. 100 milligrams over 2 hours, 10% as a rapid bolus begins. We are going to temporarily hold on other anticoagulation like a heparin infusion to reduce the risk of bleeding. We're going to be watching the PTT very diligently so we can restart full anticoagulation once the fibrinolytic storm settles. If bleeding risk had been prohibitive in using thrombolysis, we can also consider catheter-directed therapy or even ECMO support as a bridge to clot extraction. But today, the clinical scenario and the protocols align. The TPA is mixed, pushed, hung, and currently infusing. And within minutes of the bolus, we see his blood pressure climb, his SpO2 inch into the mid-90s, and the right ventricle finally is breathing easier. The vasopressors you carefully titrated taper off, oxygen requirements drop, and our patient transitions to the ICU for continued monitoring and long-term anticoagulation. So what should you remember from this case? First, pulmonary embolism is common, up to 900,000 cases a year, and it's deadly if it's missed. Second, Virchow's triad remains our conceptual cornerstone, but a high index of suspicion still rules. History and presentation over any individual score. Third, use Wells and PERC thoughtfully, but don't hesitate to draw that D-dimer or even proceed right to CT angiography when the picture fits. Finally, massive PE, interventions like thrombolysis saves lives. Prepare early, and be sure you're familiar with your facility's process for administration of thrombolytics for PEs. This will most likely be different than what you utilize for MI or strokes. That's it for today's high altitude thrombus. If you're on a red eye this week, stand up and walk the aisle. Your calves will thank you. And in the ED, keep your senses sharp, maintain your vigilant history, assessment skills, and decisive actions. These are your best defenses to keep your patients safe. I'm Kevin LaMonica. Thank you for watching This Emergency Life. Please, if you like this content, please follow and subscribe. I want you to stay alert, stay curious, stay safe until your next shift. Take care.